At the end of this program, the participant will be able to identify the principles of counterstrain OMT, identify and differentiate indications and contraindications for lumbar counterstrain treatment, identify and differentiate the diagnostic counterstrain tender points, anterior and posterior, for lumbar somatic dysfunction, evaluate relevant anatomical dysfunction indicated by presence of anterior and posterior lumbar counterstrain tender points, identify and differentiate standard treatment positions for somatic dysfunction indicated by presence of anterior and posterior lumbar counterstrain tender points. The definition of counterstrain, also called strain counterstrain. It is a passive positional osteopathic manipulative technique developed by Lawrence Jones, D.O., FAAO, that places the dysfunctional segment, spinal or other body part, in a position of comfort. This resets abnormal neuromusculoskeletal function levels closer to normal. Indications for counterstrain: somatic dysfunction, not tissue damage. This is a functional condition. It's largely concerned with how the neuromusculoskeletal system functions. Length and tension of various muscles and connective tissue do not permit return to neutral, and therefore limit range of motion in one direction or another. Joint surface apposition may be distorted so that the joint surfaces will not glide as normal, therefore limiting range of motion. Contraindications for strain counterstrain: lack of patient consent and/or cooperation, including the patient who cannot voluntarily relax. Most can be trained to relax. Lumbar or pelvic fracture, severe osteoporosis, hip or other orthotic which precludes certain positions, severely ill patient, apprehension sign, or any others consistent with good clinical judgment. The principles of counterstrain. First, diagnose the region of complaint by the mapped tender points. Then, select the tender point to be treated. Generally, treat the worst one first. Establish a tenderness scale with the patient. This is usually a scale of 1 to 10, where 10 is the initial level of tenderness. Place the patient in the position of ease in 2 steps. First, put the patient in the classic position. Then, fine-tune the position through small arcs of movement in multiple planes of motion to find the greatest position of ease. Tenderness must be reduced by at least 70%, but it works even better if you can reduce the tenderness to 0. Maintain the position of ease for 90 seconds. You will need 120 seconds for ribs, while the patient remains relaxed. Keep a finger on the tender point to monitor the point for tissue texture change. Periodically retest for tenderness, for example, at 30 seconds, to be sure that the position is appropriate. Then slowly and passively return the patient to the neutral pretreatment position. They cannot help you get them out of this position. They need to be completely relaxed. Maintain contact with the tender point during this return to neutral unless you need to release the contact with the tender point due to patient or your safety concerns. Retest for resolution of tenderness. For success, tenderness must be reduced by at least 70% or elimination of jump sign. The landmarks for the anterior lumbar counterstrain tender points are as follows. First, the anterior superior iliac spine, or ASIS. Second, the anterior inferior iliac spine, or AIIS. Third, the superior aspect of the pubic ramus, proximal to the pubic symphysis. The first anterior lumbar counterstrain tender point is on the medial aspect of the ASIS, pressing laterally. The second anterior lumbar counterstrain tender point is on the medial aspect of the AIIS, pressing laterally. The third anterior lumbar counterstrain tender point is on the lateral aspect of the AIIS, pressing medially. The fourth anterior lumbar counterstrain tender point is on the inferior aspect of the AIIS, pressing superiorly. The fifth anterior lumbar counterstrain tender point is on the anterosuperior aspect of the pubic ramus, just lateral to the pubic symphysis. The iliacus tender point is found by imagining a line that goes between the two ASISs. Picture this line bisected by a vertical line that runs through the umbilicus and the pubic symphysis. Going back to the line between the ASISs, if you take your finger 1/3 of the way medial from the ASIS toward the line that would bisect it and press deeply into the iliac fossa, you will be approximating your finger to the iliacus muscle deep in the fossa. All right, in examining the patient, the first thing that we want to do is find the landmarks. And the landmarks for the lumbar counterstrain tender points right now would be the anterior superior iliac spine and the anterior inferior iliac spine, as well as the pubic symphysis. So the first thing that we want to do is raise the shirt up just a little bit so that we can then find the ASISs, the anterior superior iliac spines. I do that with my palms, putting my palms down approximately where I think they will be. Then I transfer my thumbs to the pointed part of the ASIS. I curl my thumbs around on the medial aspect and I pull from medial to lateral against the ASIS in each case. And I would ask the patient at that time whether there was any tenderness as I tested each one. The next point that I would tend to look for would be the iliacus or iliacus tender point. If I had a line that went from the umbilicus down to the pubic symphysis, if I moved 1/3 of the way across that line medially, then what I would find is I have the iliacus tender point that is deep in the iliac fossa. So I put my thumbs there, but I have to palpate very deeply for this. So I go in very slowly and then test on each side going back against that muscle to see if there's any tenderness there. Generally speaking, I would be looking at the patient's face while I was doing this as well. The next landmark is the anterior inferior iliac spine. The anterior inferior iliac spine would be approximately 1 inch inferior to the ASIS and about 1 inch to 1.5 inches medial. And I can palpate that. If I can't find it very easily, I can lift up the leg to feel a little bit deeper and see where the muscle is coming into that landmark. Once I've found that landmark, I want to be on the medial aspect. And I'm going to pull laterally against the medial aspect to find the anterior second lumbar tender point. And I would test each side. Then I would take my thumbs to the lateral aspect and press medially against the lateral aspect to test the anterior third lumbar tender point. I then take my thumbs inferior to the AIIS, and when I take them inferior to the AIIS, this time I'm going to be pushing superiorly at the inferior aspect of the AIIS, again on each side sequentially, asking again if the patient has any tenderness. To find the fifth lumbar anterior tender point, I'm going to take my palm and put it on at about the belt line, and I'm going to go inferiorly toward the pubic symphysis. So once I've found the pubic symphysis with the heel of my hand, I'm going to transfer my thumbs to it. And on the anterior superior aspect of the pubic ramus, about 1 to 2 centimeters apart from the pubic symphysis, or lateral from the pubic symphysis, I'm going to test those 2 points for the anterior fifth. Once I find the iliacus tender point and have located the side I'm going to treat, I want to stand on the same side as the tender point. I'm going to put my fingers deep into the iliac fossa to be able to monitor it. I'm going to ask the patient to lift both knees and bring them up so that I have a little less work to do. I want to bring them up to at least 90 degrees of flexion for the knees and for the hips, and I want the legs to go apart in a position we call the frog, because it looks like you have a frog's legs. I still have my finger on the tender point, and so at that point in time I can test it. Now the part that is more difficult then, if you're dealing with a person who's larger than yourself, is getting them out of position, because they have to be absolutely passive. They can't help you, and so you have to talk them down while you take them out of position. If they activate their muscles, they may reactivate the somatic dysfunction that caused the tender point in the first place. I usually go through about 3 positions of fine-tuning, where I'll have a slight shift, either more flexion or more side bending, or maybe a little bit more rotation one direction or the other. And I can easily do these simply by moving my knees and my leg. My weight is transferred to the table, and so I don't really have a lot of lifting that I'm doing. Once I achieve the position of ease, I hold them in place for 90 seconds. After they're in place for 90 seconds, I tell them, don't move a muscle now. I have to get you out of here without you helping me at all, so just let me do all the work. I then bring the legs, the knees together, and it's important that the first 30 degrees of taking them out of position is very slow. So I will move my leg down using my forearm on my thigh to support it, and take the person down a little bit lower, sidestepping next to the table. With a person who's much larger than me, I'll then continue doing the motion one leg at a time. Don't help me again, just let me do the work. That's good. I take the foot down and then let the leg rest. I then, again, let the foot come down to transfer the weight and then slide the leg down. So that's the ergonomic way to do it. First lumbar tender point, I have my thumb on the medial aspect of the ASIS. I ask the patient to bring up both knees, and I have him lift them toward the abdomen. I'm going to take him to the point where I feel the tender point begin to soften, and I'm going to have him bring the knees over toward me and let the ankles fall toward the ground. Okay, just relax completely. At this point in time, I'm leaning into his knees, transferring weight to the table. So again, I'm not doing very much lifting. What I'm doing is allowing my weight to transfer through his knee, through his hips to the table, and the rest of my weight is on my legs. If I have him in the approximate position, I can fine-tune with a little rotation, or with a little bit more flexion, or by bringing the ankles toward me with a little bit more side bending. Once I'm in the appropriate position, I will rest my weight through the knees onto the table. When it's time, after 90 seconds, to take him out of position, I will simply move sideways. I'll ask him not to help me at all. Move sideways, transferring my weight again through the legs so that I don't have to lift very much. Once I get the feet on the table, I can tell him, okay, you can take over a little bit on that foot on the other side. And I slowly lower it down, and I lower down the other side. Now, on the second, third, and fourth points, they're on the opposite side. The second point, is this it? Okay. The second point requires considerable rotation. So again, I would ask him to, in this case, I'm going to bring the table up a little bit higher because I'm going to have to take the legs down somewhat lower. So if you'll bring your knees up again, lift them up toward your chest. Okay, let them slide over toward me. Good. Okay, that's good. Now if it was a 10 before, what is it now?
6.
Okay. And how about here?
3.
Relax. Let your hips drop. And here?
1.
And there?
0.
Okay. Once I'm in position here, I can easily maintain this again by leaning forward, transferring my weight through the patient's knees so that I don't have to support it myself other than by leaning into him. To get him out of the position after 90 seconds, I simply walk sideways. I ask him not to help me at all. I bring the feet back up on the table. Okay, let your legs drop. That's it. Slowly lower the legs down. For the third tender point, the position is going to be very similar, except that there will be less rotation. So, is that it there? Any tenderness? No. Okay. Let's bring your knees up. In this case, we have much less rotation. We do have more side bending, where the ankles are coming toward me a little bit more. Again, I'm leaning into the patient. I can fine-tune with a little bit more flexion or extension, with a little bit more or less rotation, and with a little bit more side bending if I need to. Once I have him in the appropriate position, I hold for 90 seconds. After that's done, I simply lean toward him, tell him, don't help me at all. Let me put your weight back on the table here. Don't help me. Okay, good. Now you can take over the legs a little bit. I'm going to lower them. Don't help me lower them. Just let them slide down. Okay. So that's the third. Now the fourth tender point, which again I treat from the opposite side, I'm going to bring the knees up again, or ask him to. Bring them toward your chest. And this one has very little rotation and more side bending, a little bit less flexion. And once I have him in position, I hold for 90 seconds. So the modification is that there's a little less flexion, there's less rotation, and there is greater side bending. To take him out of the position, again, I simply transfer my weight through my feet as I move sideways across the floor. Okay, now just support your legs just enough so they don't fall. Okay, let this one drop. Good. And then on the side near me, I can take it down a little faster. To treat the fifth tender point, the first thing I want to do is I want to ask him if he needs to move anything here out of the way. Okay? I find the point. Once I have found the point, I want to be treating on the same side. You actually had a point here, correct? Okay. If I ask him to bring his knees up, this time I'll put my arm under his legs. Bring your knees toward your chest, if you would, and bring his knees over toward me just a little bit and his ankles away. This is a difficult position to maintain without some support, so I put my leg up on the table. Now it's very easy to support. The weight of his legs is transferred through my thigh and leg down to the table, so I'm not lifting very much weight at all. Once I've held him in, once I've fine-tuned, I can fine-tune again with a little bit of rotation, a little bit more flexion or less flexion, and a little bit more or less side bending. Again, if I really want to take care of it quickly, I can take them into more flexion and it'll require less fine-tuning in the other directions. Once the 90 seconds is over, I'm going to again take him down slowly. The easiest way to take him down slowly from this position is to get him to about 90 degrees of hip flexion, and then just ask him to let the feet drop toward the table. Once the feet are down on the table, okay, take over your legs. Now relax. Once they're down, I can simply take down one at a time, slowly. And afterward, I would again test the tender point. The first 5 posterior lumbar counterstrain tender points are located on the inferolateral aspects of the spinous processes of the respective vertebrae, lumbar vertebrae 1 through 5, coming in at about a 45-degree angle and pressing against the inferolateral aspect of those spinous processes. The second set of bilateral posterior lumbar counterstrain tender points is on the posterolateral aspect of the transverse processes of each of the 5 lumbar vertebrae. 5 is particularly difficult to access due to the amount of superficial tissue between it and the palpating finger. The upper pole 5th lumbar tender point is located on the superomedial aspect of the PSIS. And the lower pole 5th lumbar tender point is located approximately 2 centimeters below the PSIS, pressing superiorly and anteriorly toward the PSIS. 2 additional tender points can be found. They are found by finding the greater trochanter of the femur and the superior aspect of the iliac crest, dividing that distance in half, and then palpating approximately 1 center medial to the tensor fascia lata, which will be going between those 2 structures. That would be the posterior lateral lumbar 4 tender point. The posterior lateral lumbar 3 tender point would be located halfway between the PLL4 tender point and the upper pole 5th lumbar tender point, about 3 centimeters below the iliac crest. Both of those relate to the gluteus, or the gluteus medius. And we should be coming up to the point where we can feel the 12th rib coming in. So another way to do it is to find the 12th rib coming into the T12, find the first lumbar. When we find the first lumbar, again, come in at a 45-degree angle toward the inferolateral aspect of the spinous process on each side. Any tenderness here or here, here or here, here or here, here or here, here or here. Once we've tested the spinous processes, we can test the transverse processes, which are directly lateral to the spinous processes at each level. So we go back up to the first lumbar and go out laterally about 1.5 inches on somebody approximately this size to feel where the transverse processes are, and we press directly anterior against them, pushing them toward the table. Any tenderness here or here, here or here, here or here, here or here, here or here. Once we've tested the spinous processes and the transverse processes, the next thing is to test the upper pole 5th lumbar. To find that, again, we find the PSISs, the posterior superior iliac spines. We go on the superomedial aspect, and pulling downward against the superomedial aspect, we're going to pull from medial to lateral, superior to inferior, at about a 45-degree angle, and also going anterior as well. Any tenderness here or here. Okay, so that's the upper pole 5th lumbar. Again, finding the PSISs, if we go about 2 centimeters inferior to the pointed part of the PSIS, and we take our thumbs and push directly toward the head and anterior. We're going to be pushing up toward the PSIS. Is any tenderness here or here?
No.
That would be the lower pole fifth lumbar tender point. There are two more tender points that we can use. One would be the lateral posterior lumbar third tender point. To find that, we find the iliac crest and the greater trochanter. We go about halfway between and about a centimeter medial to the tensor fascia lata. We do that on each side, and again test any tenderness here or here on the left. Now between that point and the PSIS, if we find the upper pole fifth lumbar, if we come halfway across between those 2 points, we'll find the posterior lateral fourth lumbar tender point. Any tenderness here or here on the right. Okay, good. All right. Our exam is this rapid and systematic. I find the 12th rib, I come up to the 12th thoracic, I come to the first lumbar. Any tenderness here or here?
No.
Here or here?
No.
Here or here? Here or here? Here or here? Any tenderness here or here? 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 Any tenderness here or here? Here or here? Okay. Any tenderness here or here? Here or here? Okay. For any of the posterior lumbar tender points, you have a couple different positions that will take care of all of the treatments. The easiest way is to take the leg, raise it up like this, ask the patient to lift his thigh off the table and put your knee underneath it. As I have him underneath that, I can now use a little bit of abduction or adduction to fine tune. I already have him in extension. And once I do that, I can rotate him into some external rotation with the leg and then fine tune him to get the point gone. Okay, if it was a 10 before, what is it now?
0.
Okay, so this is, we've immediately gone to the position. If we had not immediately gone to the position, we could add in a little bit of abduction or take a little less abduction. We could actually lift the leg up a little bit higher or put a pillow on the thigh to do the same thing to get some more extension. And the other thing we can do is we can add in some additional external rotation by bringing the ankle down, which will externally rotate the thigh further. Once we have him in the appropriate position, again, is this a 0?
Yes.
Once we have him in the appropriate position, it's very easy just to say to him, don't move at all. I'm going to slide my leg out from under you. Don't lift your leg, just let your leg drop to the table. I then turn sideways just a little bit, let the leg return to neutral, take my leg down, and I haven't had to do very much work at all. At that point in time, I simply retest the tender point again and see if it's returned to normal. Trying the same technique with the upper pole fifth lumbar, I'm pulling laterally and inferiorly against the superomedial aspect of the PSIS. Again, I lift the leg slightly. I ask the patient to raise the thigh. I put my knee underneath it, and I again position him so that I feel the tissues relax. As I feel the tissues relax, I ask him on a scale of 10 what the tenderness is. If it was a 10 before, what is it now?
0.
0. Okay, if I need to, again, I can take the leg further out into abduction or a little bit more adduction. I can take the thigh a little bit lower or bring it up a little bit higher. I can do additional external rotation or less external rotation, because sometimes it will require less external rotation. To return him to neutral position, again, I ask him to be completely passive, don't move a muscle, and I will raise his leg up to take it out of the rotation, and then I'll say, okay, just let your leg drop to the floor as it slides off, or drop to the table as it slides off my leg. I take him down slowly, take the leg down against the table, and I have him back in position. To put him into position, I can raise up the table a little bit. I can have him bring his leg over toward me, let it slide off the table to where it's on my knee. I shift my knees so that my one thigh is above his knee and the other thigh is below. Now I'm going to bring the table up again, and as the table comes up, I'm going to move in a position to where his knee goes forward and under the table. When I have him in this position, I can simply let it rest there and hold it. Okay, good. Once I'm sure that he's been treated and adjusted in for the appropriate length of time, I'm going to slide down to get out of the position, bringing the leg down. Again, using the stool and then the table to take him out of position so that he has either no or minimal use of his own muscles, then sliding the leg across on the table and simply letting him get back into neutral position, at which point in time I can retest. After locating the first lumbar, I go to the inferolateral aspects and start testing. Do you have any tenderness here or here? Do you have any tenderness here or here? Do you have any tenderness here or here? On the right. Any tenderness here or here? On the right. Any tenderness here or here? On the right. Here or here? Okay. Do you have any tenderness here or here? Here or here? On the left. Here or here? On the left. Here or here? Are they any worse on the left than they were on the right, on the others we were testing?
Yes.
Okay, so the left is worse. Any here or here? No. Okay. Any tenderness here or here?
No.
Okay. Do you have any tenderness here or here?
Right.
On the right. Is that any worse than the ones on the left?
Yes.
This is the worst one so far?
Yes.
Okay. And do you have any tenderness here or here?
Left.
On the left. Which is the worst? The one over here or this one?
That one.
This is the worst point so far?
Yes.
Okay, this is the one that we'll treat. So having selected this point to treat, what I'm going to do is I'm going to raise his leg. I'm going to ask him to lift his knee off the table, put it on my thigh, and now he's given me about all the help that I want him to give me. I'm going to put him into some external rotation. Okay, if it was a 10 before, what is it now?
4.
Got a 4. Okay, so I need to lift this higher. So I simply slide it up along my thigh. Okay, how about now?
0.
0? Okay, 0 is good. So I've got him in external rotation. Would you let me know at 30 seconds then? And in 30 seconds, I will reprobe the point. Right now, I just have my finger lightly resting on it. I'm not applying deep pressure. I'm not trying to get avascular compression, just a light monitor to see if I can feel any tissue texture changes as the body relaxes the gluteus. In this case, I think I probably have the gluteus medius that I'm working with. This is the posterior lumbar 3 lateral. Okay, so now we're at 30 seconds. Okay, if it was a 10 before, what is it now?
0.
0? Okay, that's good. So now we're going to maintain this for another 60 seconds because the total treatment is for 90 seconds. And so I have him in position. I'm just going to maintain this position. It's pretty easy to maintain. I've got the weight transferred onto the table. So I don't really have a whole lot of his weight. He helped me get into the position, and so I didn't have to do a whole lot of weightlifting. Now, he has to stay completely passive once he is in the position, and we've gotten the tenderness reduced. We want it reduced to 30% or less of the original tenderness, but if we can get it to 0, that's a whole lot better. I find that my patients would much rather have a bullseye than something in the yellow ring. So we're now at about 60 seconds more, so that's 90 seconds total, so please just stay completely relaxed. I'm going to slide my leg out from under yours. Just let your leg slide down on mine. Don't move a muscle. Let me do the moving. So I put them down slowly, passively. Extend the leg out. And now to retest, okay, if it was a 10 before, what is it now? 0. Okay. Larry Jones had his own way of treating low back pain complaints. First, he ruled out tissue damage or other serious problems by doing a standard medical examination. He listened to the patient as he took the history, asked questions, and tried to figure out what the problem was. If neurologic tests were then normal, pulse is good, any special tests were normal, and gross observation did not reveal a hidden serious complaint, he examined for tender points. With low back pain, he didn't just examine the lumbar spine because there are other causes for low back pain. But the lumbar region was a good place to start. He would then examine in the pelvis, as well as the thoracics, and possibly down to the knees. Why do I have to keep my finger on the tender point? You keep your finger on the tender point to monitor tissue texture changes during the treatment. This also assures the patient that you're testing the same location at the beginning and end of the treatment. Do I keep applying pressure on the tender point? No. Counterstrain is not like acupressure. The finger is in place as a monitor and to be sure that the same diagnostic location is probed when retesting. Does counterstrain treatment always have to take 90 seconds? Lumbar counterstrain works best if the position of ease is maintained for 90 seconds by the clock. This seems to relate to spinal cord reflexes. Ribs require 120 seconds. Do I have to use the standard position described for any particular tender point? Experience has demonstrated that using the classic positions, along with fine-tuning, generally assures success. On a rare occasion, a different position may be indicated. What if a tender point doesn't respond? If a tender point in a mapped location does not respond to placement in the classic position, let the patient's decrease in tenderness when you probe guide you to a successful position of ease. If this does not work, clinical suspicion should be aroused that somatic dysfunction is not the cause of the tenderness. Look for another medical cause for the patient's pain. Can I take my finger off the tender point if I need that hand to lift the patient out of the treatment position? Yes. Patient and physician safety are paramount. However, it is important to maintain the monitoring finger on the tender point unless safety necessitates its removal. Are all tender points counterstrain tender points? No. Counterstrain tender points are points of tenderness in specific mapped locations indicative of somatic dysfunction. Other causes of tenderness, such as infection, inflammation, or trauma, can also produce tenderness which does not indicate somatic dysfunction. What happens if I return the patient to neutral too quickly? Returning the patient to neutral slowly is extremely important. It is during this process that the dysfunctional muscle and connective tissue are stretched back to normal length. If the stretch is performed rapidly, the somatic dysfunction may be reincited. Does it matter if the patient actively helps in the return to neutral? Yes, it does. If the patient helps in the return to neutral, he's generally contracting the muscle you are trying to slowly stretch back to normal length. The muscle then resists the stretch and returns to the dysfunctional shorter length and higher tension level that it had before the treatment. This will maintain the somatic dysfunction. What happens if I can't get at least 70% resolution of the tenderness with positioning? Approximately 70% reduction of tenderness seems to be the threshold of success. If the tenderness cannot be reduced at least 70% by positioning, the treatment will generally not be successful. One exception to this is if the patient has jump sign when originally probed. If that is the case, if the treatment reduces the tenderness to the point where the patient no longer has jump sign, it should be successful.